All right, welcome everyone back to another virtual shadowing session. This is going to be our first of the spring term. I've really missed these sessions, and I'm so glad that we could get back to it after a little over a month of a hiatus. Today, we're going to be joined by Adam. Adam is an emergency medicine resident physician. He's going to be going over a few cases and the specialty in general. I know that quite a few of y'all are interested in emergency medicine, so we're excited to deliver this session today. A few reminders for you, especially if you're new to virtual shadowing, especially if you've just joined us for this semester. First thing is that we have a Q&A at the very end of these sessions. So typically our structure is we have speakers who join us, present on their given specialty or profession. We have speakers ranging from physicians to PAs, really everyone in the healthcare sphere to deliver exposure to pre-meds, pre-PAs, and a number of other pre-health students. But at the end of those sessions, at the end of those presentations, we give a devoted 15 to 20 minutes at least of Q&A. So any questions that you have for Adam or any of our future speakers, feel free to type in the chat, and we'll get around to them at the very end of the session. We'll go through them in the order that we receive them. Outside of that, we also have an email listserv where we send out updates for future shadowing sessions. So please, if you have, or if you're interested in hearing more about our shadowing sessions, please feel free to subscribe to our listserv. You can do that either by emailing us at community.h4h@gmail.com, or go onto our website. At the very bottom of each page, there is a subscription form. Feel free to fill that out with your name and email. You'll be good to go. And then one last announcement. So over this past semester, just recently, we changed our URL, our website link. So for those who might be confused or who noticed that, our new website link is hearts4health.org. All right, so if you ever want to log on to our website to access quizzes or any of our other content on there, that's the new URL. But with that said, that's really all. If you guys have any questions, feel free to email us at the email I mentioned earlier. I'm going to repeat that email later on at the very end of the session. So if you didn't catch it, I'll be sure to repeat it there. But Adam, feel free to take it away.
Awesome. Thanks, Michael. Hey, everyone. I'm Adam. I'm a fourth year emergency medicine resident at Washington University in St. Louis. We're going to start just kind of with my background and how I got into medicine in general. I took kind of a non-traditional approach, which I know a lot of people do now. So I did want to share that. And I apologize for my kind of non-office background. I'm getting ready to go into a night shift. So I had to do this from home as I get ready, but I'm excited to be here with you guys. I will warn you up front, we will go through a couple stories with a couple pictures. They are pretty graphic. There's going to be a graphic warning before each one. So please, if you're not into that, feel free to just listen along. All right. And then at the end, I'm going to have my email. I'm happy to answer questions. Feel free to shoot me an email as well if you have any questions, concerns, things like that. So, all right. So we'll start with a brief introduction, why I went into the ED, some stories and pictures, and finish it off. So I started at community college, actually. I wasn't set on medicine from high school, which I know a lot of people kind of are. I think that's very difficult to set your entire career in motion at the age of 16, 17, 18. So I was kind of into an engineering field. I was into technology. I was into STEM, but I didn't really know exactly what I wanted. So I started at community college for 2 years and kind of took some core courses and fell in love with anatomy, physiology, and medicine through that. I then moved on to the University of Maryland, College Park. I'm from Maryland, from the East Coast. I completed 2.5 years there just because of some course transferring credits. I did my pre-med courses there. I did a little bit of research, but because I came in as a transfer, I was a little limited. I didn't get in on some of the labs, things like that, as a freshman, like a lot of people did, which I felt like that put me at a pretty big disadvantage. I was one of those juniors, seniors who people didn't really care to put in their lab or to get involved in activities because I was almost graduated. So I don't know if anybody listening is in that boat as well, but it was definitely difficult for me. So because of that, I took a gap year or year and a half. I worked at a place called the Living Legacy Foundation of Maryland, Baltimore. This is an organ procurement organization. Basically, what they do is receive skin grafts from all over the East Coast, process the skin grafts down to the correct sizes, and send them out to hospitals for burn care, wound care, things like that. We also recovered tissue, so we recovered skin. We had an operating room, things like that. But I worked on the processing side. I did that with a bachelor's degree to kind of buff up my resume, get a little bit of clinical experience in there. And then I also worked for the Lieber Institute for Brain Development. This was just kind of an internship at a research center. There are a lot of these around. Again, I'm from Baltimore, so this is what we kind of had near us. This was to get more of a research background built up. Getting into med school is honestly the hardest part of the entire journey. You have to hit all those check boxes: research, clinical, volunteer work, all of that stuff, and then you still have to be like an Olympic athlete or something to get in. It's really difficult. I don't really know how they make the decisions, but you do your best. One piece of advice while we're talking about this is it's going to be hard no matter what you do, and you may get in, you may not get in no matter what you do. So do something you enjoy and do something that you think is going to benefit you in general, not just something that's going to buff your resume. Because even if you do all the right things, there's still a chance. So do something that makes you feel happy, fulfills you a little bit, and you can enjoy while you're working on your applications. Anyway, so this place, basically we took brain samples from Johns Hopkins Hospital, brought them over to our institute, and then we would frozen section them and catalog them for different researchers. It was a big lab that had different investigators there. So then I moved to St. Louis. My partner got into master's program at Washington University here, so I came with her. And I worked for another organ procurement agency called Mid-America Transplant. This was just like the Living Legacy Foundation, except this time I was harvesting tissue. And by tissue, I mean bone, skin, eyes, hearts, heart valves, things like that. So this is in people who were not alive anymore. So we didn't need a surgeon to remove the organs while they were alive and transplant them. This is for hard tissue, so like bones. They would break the bones down into a kind of a matrix and use it for fracture repair, things like that. And I have some pictures here. This is going to be slightly graphic, so just giving you a warning here. So this is the kind of stuff that I would harvest. We would take hearts out for the heart valves. We would take the aorta out for grafts for people who suffer aortic dissections or aortic injuries. And then the picture on the far left there is how we would access that. It was a little bit gruesome at times, but it was a great learning opportunity as far as anatomy, physiology, things like that before even getting into med school. So these kind of options are out there. And if you kind of look around and decide you want to do more clinical work, you can do that, and that will definitely kind of put you ahead of the curve. After that, I applied, or during that time while I worked there, I applied for medical school. Oh, I skipped my medical school slide. I applied for medical school. I applied for about 50 or 60 programs. I did a bunch of clinical work and research work. I got one interview. And I got one acceptance. So I guess it's all it takes. But I got accepted to Virginia Tech, Carilion School of Medicine in Roanoke, Virginia, down by Blacksburg, where the main campus is. It was a great school. It's a very small school, 42 students per class. It was a newer program when I entered, about 5 years in. And we got to work kind of one-on-one with pretty much all of the physicians in the program because we were so small. So that was a huge plus. Throughout medical school, you do all of your different rotations. I did an emergency medicine rotation midway through my third year. I thought I wanted to go into internal medicine because I really liked kind of the pathophysiology and diagnosing people. And then I realized I also liked everything. I liked OBGYN, I liked psychiatry, I liked pediatrics, and internal medicine locks you into adults only. So when I rotated in emergency medicine and I saw you could see pretty much anything, I kind of fell in love and went that route. So during medical school, you get a chance to rotate at different institutions. In your fourth year, you can do away rotations, late third year, early fourth year, to kind of show your interest and to gauge interest in other programs. So I came back to St. Louis because I had, I knew the area, I knew some of the people around here, so I wanted to check out their program, and just kind of fell in love with it. So here I am, 4 years later. So the big question is, why did I go into emergency medicine? I alluded to a little bit earlier, but here are a few pros. And I was working on this on a night shift last night a little bit with my colleagues, and I was asking them too, what are some things you like and don't like, so I could get kind of a broader picture for you all. As a pre-med, I know it's kind of hard to think about the actual job itself when you're still just trying to get into medical school, get into PA school, MP school, whatever you're trying to get into, and you can get hyper focused on that specific goal. But I encourage you to kind of look at the broader picture and all the different jobs available to you and kind of what you want to do in the long term, because it's a huge commitment. And if you get to the end and realize that there's something else you'd prefer, it's really difficult to kind of switch gears. So doing things like this shadowing definitely helps, so you can get different perspectives. So pros to emergency medicine: number one, it's shift work. And by that, I mean, you come on, you work a certain number of hours, 8, 10, 12 hours, and you're done. Other specialties, you may be on call for a week. You're the doctor for the medical floor for 1 week. You go home, like you work 12 hours, you see all your people, and then you go home. But if anything happens, they call you and you have to come back in. In primary care, your patients will email you, will message you. You have to follow up with them basically any time of the day or night. In the ER, you show up, the person leaving tells you about their patients that you take over, and then you do that at the end of your shift. I turn my phone off when I leave. I put my bag in the car. I forget about work. Huge plus for me. 8-hour shifts. A lot of places will allow you to do 8-hour shifts. You can kind of pick, and you usually have a shift requirement. So if you do 8-hour shifts, you may have to work more shifts overall, but 8-hour shifts are amazing. No rounding, huge plus. You'll find out in medical school, rounding, you may love it. I hated it. You get together with a team, you get your attending physician and all the residents, and you go one by one through every patient room and you talk about the nitty-gritty of all their problems, which is important, but I want to focus on the big problem, like why they're in the hospital. And rounding can take anywhere from 3 to 8 hours, depending on where you are. So you don't round in the ER. You see your patients, you put some orders in, you take care of them, and then you figure out if they need to come into the hospital or if they're okay to go home. Work-life balance. Like I said, the shift work, when you come home, you're done. 8-hour shifts. And then there are a lot of different avenues out of emergency medicine. So if you don't want to be in the actual ER all the time, you can do a fellowship in things like sports medicine or ultrasound, medical education, things like that, to where you can work in a clinic part-time doing something niche, and then part-time in the ER. And I'll get into that a little bit later. You're kind of a jack of all trades. The skills are very transferable, so you can see anyone. For me, when an ER doctor is kind of synonymous when somebody says out in public, is there a doctor? It's can you take care of any problem that arises, no matter what it is? It's not, I can't take care of an OBGYN concern. I can't take care of, a psychiatric concern because, I'm a urologist or whatever. You basically can handle anything. And that's kind of how the ER works, is you don't know what's coming in the door next. So you may see somebody with chest pain and then follow it up with an 8-year-old kid with a cough, and then a 32-week pregnant woman with contractions. So you kind of get a little bit of everything. And now this is an interesting point. that I wanted to include. A lot of people say that in the ER, you don't really get to specialize in anything at all. And I like to argue that we specialize in resuscitation. So we are the experts at fixing a critically ill patient. When somebody comes in and you have no idea what's going on with them, you don't have any medical history, you don't have a chart to read, and they are crashing and you need to fix them, the emergency medicine doctor is the one who is the expert at that. So just like I said, a urologist is the expert in genitourinary concerns, we're the expert in managing a critically ill crashing patient. So plus you get to, work with and learn about every other specialty. Less administrative nonsense. This came from one of my attendings last night. When you're in the ER, you get to work kind of on your own, depending on where you are. Like I said, shift work, and you really don't have to deal with as much bureaucratic issues that the hospital system provides. So some of the internal medicine doctors, some of the critical care doctors, they have to work really closely with a lot of the kind of ins and outs of the hospital as far as patient flow, where they go, how they get there. And in the ER, you just take care of patients however you need to and leave at the end of your shift. And then you get to be as specialized as you want. So like I said, you are a jack of all trades. You can learn as much about urology and do as much as you feel comfortable with, or you can learn a very little about urology and just call your consult early and they can guide you in your care. So if you are in an academic center and you want to learn kind of how to do some procedures that aren't common or aren't typical of the ER, it's still within your scope of practice. So you can still learn how to do those things, do them in the ER, and then send the patient home with a urology follow-up. Or if you're not comfortable with that, or you're out in the community center and you don't have a lot of help, you can call a urologist somewhere else, get recommendations, and send the patient to them. So it really varies how much you want to, dig into a certain specialty. And then it's hands-on. This is kind of, I think emergency medicine is as hands-on as you can get without getting into surgery. So we don't do surgery. It's kind of a common misconception I've seen with the general public. We don't take patients to the operating room as emergency physicians. We stabilize them before they go with the surgeon, but and we do a lot of procedures in the ER, critical procedures, but we don't operate or take them to the OR. So it's a very hands-on field. And you work under pressure. So if you're someone who does well in, critical scenarios, or you have to think on your toes, this is the kind of spot for you. I'm very much a problem solver. I like working through non-typical problems. A lot of patients that come in don't follow the textbook. And so you kind of have to use some non-conventional techniques sometimes. We actually in our ER have what's called the MacGyver Award. So whoever uses the most unconventional approach to solve a medical problem gets nominated for it. For example, we had a patient who was shot in the leg, the upper thigh. And when you get shot in the upper thigh, the bullet can travel up, down, pretty much anywhere. I've seen it shot in the thigh and the bullet's in the chest. So we couldn't get X-ray to come and find the bullet. They were very busy, so we had to find it on our own. So my colleague went over to the security right next door and grabbed the metal detector wand and started wanding the patient up and down and actually found the bullet in their thigh with the metal detector. So kind of interesting, unique ways to manage patients in a resource-limited setting. All right, so I'm kind of hyping up this specialty a lot. Let me get into some of the cons here. Some of these don't necessarily apply to me, but I know they apply to others, so I like to mention them. So no continuity of care. You don't see your patients again. Well, you're not supposed to see your patients again. I live in St. Louis. I don't know how familiar you all are with this area, but it is a large metropolitan area with a lot of low SES patients, a lot of lower resourced patients. So we do have some people who come in every week, every day, multiple times a day. So I do see the same people often, but overall, you don't follow a patient throughout their medical course. On that same note, we are the healthcare safety net. So where the healthcare system fails in other departments, we pick up the slack. So we end up being people's primary care doctors. We follow up operations and operative complications when they should see their, their surgeon in the clinic. People who don't have insurance, who can't afford healthcare, they come to us for their healthcare. So we accept all these patients, and this isn't a con on the fact that I have to see these patients. It's a con on the fact that we have to deal with the healthcare system shortcomings, which is frustrating. Like I said, some people think of us as no dedicated specialization. So a lot of people want that specific niche, like they want oncologic urogynecology, where they only specialize in tumors that affect the urinary tract surrounding the uterus, things like that. Or like a glaucoma specialist, which is an ophthalmologist who specializes specifically in glaucoma. Very, very niche. Again, I like the fact that we can do everything. Some people really want to be super experts in one specific thing. Working under constraints. This, I was referring to more of the emergency department doesn't always get as much funding, and we don't get as stocked as well, and we don't get recognized as much by as much as other parts of the hospital. So we oftentimes don't have the tools we need to treat the patients. And I'm going back to that example with the gunshot wound. We didn't have X-ray available for this patient, so we had to utilize a non-conventional technique, which can cause patient safety issues at certain times. But like I said, we do what we have to get the patients treated. Flipping nights and days. This one is the worst one for me. This month specifically, so I'm a resident still, so my schedule sucks. We work 12-hour nights, we work 12-hour days, we work 8-hour nights, and we flip all over the place. I have flipped nights and days 6 times this month, in the month of January. And it's just been brutal. This is a little unusual. It's usually not this much, but even as an attending or when you're done with residency, you will still have occasional flipping nights and days. There are people who want to be nocturnists, though, who work only nights, and they can kind of work a deal out with the hospital where they don't flip them, so you only stay on a night schedule. So some people like that. I don't. Schedule variability, same thing. You work days, you work nights, you work weekends, you work holidays. Places that have clinic, like dermatology office, cardiology office, things like that, they will only be open Monday through Friday, 9 to 5. And then again, no OR, no clinic, no rounds. I like this, but a lot of people, they need to be in the OR. They love the OR. They like having clinic, a scheduled or like a regimented 9 to 5, or they like rounds. So what do people do once they graduate from residency? What do you do as an ER doctor? So you can work in the community. This is in a hospital that doesn't have a big name attached to it, doesn't have a lot of resources. So let's take Johns Hopkins. That's the opposite of a community hospital. That's purely academic. If you go out into the middle of nowhere, Missouri, there may be one hospital within a 50-mile radius. They don't have those subspecialty urogynecologists who do, cancer as well. They have an ER doctor, they have a medicine doctor, and maybe an ICU doctor. And that's pretty much it. So the population, the patients you see out there are much different, usually less sick. And if they are sick, you send them somewhere. Academic, this is the opposite. This is you have all the resources available to you. The difference here, the reason people would pick an academic center or a community center over an academic center is you get to do more on your own. In an academic center, such as where I am at WashU, if we have, say, a broken bone, we have all the orthopedic residents who need training to fix that. So I don't get to fix that as much as they do. If we have somebody who has a urologic problem, we have urology residents who need to practice. So I don't get to train that with that way. So at my center for residency, they have us drive out to community hospitals to get that training that we have to kind of give up to the other trainees. And then you can do fellowship. So a lot of people don't realize how many there are out of ER, but there are a lot more than I anticipated. One of the big ones is sports medicine. So you can specialize in sports medicine. You can work different games. Usually ER doctors are the ones who are at the sporting events for, the NFL, the MLB, things like that. So we actually contract with the St. Louis Cardinals for the baseball team here and the St. Louis Blues for the hockey. So we get free tickets, but we have to work. So it's pretty cool. You can also do office clinic time as a sports med doctor. So you could do part-time clinic, part-time ER. EMS. So this is paramedic kind of training. So you would be the medical director for paramedics. You would be the medical director for if you have a local SWAT or tactical medicine team. And you would kind of direct all that. That includes EMS like ambulance rides. It includes helicopters, life flight, like I said, tactical. During our rotation with them, we got to do some scuba training and search and rescue, all that kind of stuff. Ultrasound is a big one now. Ultrasound training, you become an expert at multiple different types of ultrasound procedures. You can become the director of ultrasound, where you train people, you look at all the images and QI them, so you kind of review them for people and decide whether or not they're accurate, if there's a misdiagnosis. And this is a Butterfly, which we're starting to incorporate. It's a portable ultrasound that you plug into your phone, and you can just scan anyone on the go. And then this is the fellowship that I'm doing, medical education. These are two people, a part of a podcast called MRAP, which is a big free online medical education podcast based out of California. And basically they put out videos, podcasts, lectures, all that kind of stuff for free for emergency medicine residents or just medical personnel in general. And then critical care is the last really big one here. You can do critical care out of multiple specialties, but ER is one of them. And in this, you would become an ICU doctor. So you would work in the ICUs, you'd be an intensivist. So you would spend part-time in the ER, part-time in the ICU. Okay, so I was gonna just tell you about kind of what a day is like for me, but we actually made a video for our program called A Day in the Life. Michael, where am I on time?
We're pretty good.
Okay. So this is one of my colleagues, Miros, and she kind of walks us through a day in her life as an ER resident. Just as a disclaimer, this was for incoming residents or medical students applying. So a lot of it's specific to our program, like we have free coffee and things like that. So, but I just wanted to give you a video so you can, visually see what it's like to be in the ER, to kind of work as a ER doctor. And let me know if the sound works.
We can't hear the sound on our end.
Okay.
It might be your headphones. I think it might be not going through due to that.
Let me try to mute and see if that works.
No, it's still not going through.
I can send a link to this video instead, and I can just give you guys a brief overview of what it's like. So typically we have shifts in the ER that range, like I said, from 8 a.m. or 7 a.m. to 3 p.m., 3 p.m. to 11, or 11 to 7. So we kind of have 8-hour chunks. On the weekends, we do 12-hour shifts. So usually we, as a resident, we'll get up about an hour and a half before our shift, get ready, Roll in a little bit early, maybe 30 minutes early, look at the patients that we're taking, look at the waiting room, and look at the section of the ER that we're working in, and kind of get an idea of how busy it's going to be. I will review my patients before I go in, just a quick scan to see what's going on, to see how sick they are, see how many I'm going to be taking. We'll go into the ER, we'll do our sign out, which is where we all sit down and the off-going ER doctor will present their patients to me and I will assume care of them. That's my chance to ask any questions about their pathology, about their illness, what's been going on. One of the criticisms of ER I'll bring up is sign out. They say that because we have such frequent sign outs, that's a time where medical error is at its highest. And because of that, our program has taken a lot of liberties, and a lot of programs have, to where sign out is a very structured process. We are not to be interrupted. We have a room, we shut the door, we tell the nurses we're in sign out. And we go through each patient as a group so that everybody has a chance to hear about them. Everybody has a chance to ask questions about them, and review all of their information. After sign out, we start picking up any new patients. I usually go do my own little mini rounds where I just go walk around and check in on everybody. Depending on where you work, my department has 3 main sections: a critical care area, a normal area, and then a fast track. Fast track is kind of like urgent care, where people with less severe complaints come in, usually get seen pretty quickly, and are able to get discharged and go home. That's to help offload some of the patients in the waiting room that maybe don't need to be in the emergency department or can be treated quickly. The main areas for your bread and butter: chest pain, belly pain, back pain, dizziness, that kind of thing. The critical care area is for your sickest patients, your gunshot wounds, your heart attacks, your strokes, that kind of thing. So depending on where you are, changes the way you kind of come in and start your day. In the trauma area, we don't get to wait when a patient comes in. In the other areas, they can sit in the waiting room until we're ready. In the trauma area, while we're signing out, inevitably, only when we're signing out, all the patients come in, and we have to stop, sign out, and go see them. We could be busy or slow for an hour beforehand and an hour afterwards, but as soon as we start signing out, all the patients come in for some reason. So we have to get up, stop whatever we're doing. We get a page from our charge nurse who says, we have an EMS coming, an ambulance coming with a gunshot wound to the chest. Be here in 5. And we all have to go to the room and get ready, and they're there in 5. We have no other information. That's all we got. So that's kind of the exciting, fast-paced, severe critical illness side of the ER. Honestly, that's my favorite part of the ER. While you're working, you're going to see a lot of patients who are there for things like, hungry, cold exposure, homelessness, medication refill, toothache, toe pain. I saw a guy for chapped lips, things that don't really need to necessarily be there, mixed with failures of our healthcare system and just lack of social support. So inevitably, you have to see those patients as well as the exciting sick patients, but it's part of the trade. Like I said, at the end of your shift, you sign out. I turn my phone off. I go home. Usually I'll work anywhere from 3 to 6 shifts in a row. And that's as a resident. That's not when you're done. When you're said and done, usually you work anywhere from 15 to 26 hours a week, depending on your contract, and you can negotiate that. And then I'll be upfront, the salary for emergency medicine ranges pretty widely. In academic centers where you work with residents and you have all the support, you make less. If you're in the community, you make more. It ranges anywhere from $280,000 all the way up to $460,000 a year. Roughly $150 an hour up to $300, $350 an hour, depending on if you're hourly or salary. But yeah, and then as a resident in emergency medicine, we rotate through multiple different specialties because we need to get experience with OBGYN because I have had multiple deliveries in the ER. All of the ICUs, we rotate through every ICU that we offer, the medical, surgical, cardiothoracic, pediatric, all the ICUs. Anesthesia, we rotate in the ORs to get better at intubation because we have to intubate or place breathing tubes in patients who are critically ill. And so we want to get practice with patients who are in a controlled environment like the OR before we have to do it on people who are crashing. And I think those are the big points. Please, if you have questions, let me know at the end. Is it not going to progress here? There we go. Okay, that's pretty much what the life of an ER doctor is and where you can go, what I like about it. So now I have some stories. The part that a lot of you were probably wanting me to get to. This is going to have graphic content. It's going to get progressively more graphic. So please, if you're feeling not great about looking at some of this stuff, feel free to listen in and not watch. But we'll start with something not too bad. So this patient I saw as an intern, my first year in residency, he was a 60-year-old male. He came in for a wound check, saying he had a wound on his arm. He says it's been there for about 5 years, and at that time the doctor said it was just a cyst. Today it started bleeding, so he wanted to get it checked out. I went in the room, and I was an intern at the time, so I didn't know a whole lot about medicine, but I saw this. That's his arm for reference. Here's a better view. I didn't know much about medicine, but I walked in the room and I said, "Sir, you have cancer." This was growing for about 5 years, and he had never had it checked out by an actual physician. It actually started outgrowing. So this was a tumor. This is a soft tissue tumor or a muscle tumor called a sarcoma. And it started outgrowing its ability to supply blood to itself. So it started, the skin or the cells that it was growing could not survive and were breaking down. And that's why it was bleeding and kind of flaking. And you can see in this picture, he has a lot of these engorged veins and new veins. So that's kind of what cancer does, is it'll not just grow the cells, but it'll grow everything it needs to keep itself alive. So it starts growing new blood vessels, bigger blood vessels, until it physically can't sustain itself, which is what was happening here. So he ultimately had his arm amputated. And this was 4 years ago, and he's sarcomas are very aggressive, but I've been checking up on him, and he's still alive. He's still actually doing okay. He actually declined therapy and wanted to do, more, I guess, homeopathic measures, eating fruits and veggies. Seems to be working out for him, I guess. Twin deliveries. I don't have pictures for this, but this was a very interesting case. It was a 30-something-year-old woman. She came in for flank pain on her side. Sounded very much like a kidney stone, kind of going down to her groin, got really tight, crampy, things like that. So she was recently seen in the OBGYN clinic as a routine follow-up, and she got the Depo-Provera birth control shot, which she had been getting. And she was kind of screaming in pain, yelling at us to give her more pain meds, being very aggressive about it. So during she came in right before we did our sign out. So again, we gave her some pain medications and told the nurses, like, hey, we're going to go sign out. Just unless there's emergency, we'll come and see her in a bit. Still saying she's having the pain. And then during sign out, she now is calling for doctors and is having vaginal bleeding. We all rush out there, and she's actively pushing and delivering. A baby's head is coming out. So we rush in, we deliver the first baby, we put the baby on the warming table. We have like the baby warmer with all the medical supplies. And she had no idea she was pregnant. And OBGYN had no idea she was pregnant. So as we're resuscitating this baby, she starts screaming in pain again. And we thought maybe she had some sort of like uterine hemorrhage or something going on, a complication. And we looked down and another baby's coming out. So she had twin deliveries at a very premature age. I believe it was 24 weeks that she could remember, which is right at the age of viability of whether or not a baby can kind of survive. And she had two. So the second baby wasn't breathing and needed a breathing tube placed, but both ultimately, I believe, survived. So no OBGYN was there. This all happened within the matter of 15 minutes, 20 minutes. So by the time we have an emergency OBGYN pager that we set off, but by the time they got there, babies were already out, and we had already resuscitated them. So don't let your guard down. This one was over at the pediatric ER. So we work at, I forgot to mention, as an ER doctor, you are also board certified in treating children. So in residency, we spend 25 to 30% of our time at the children's hospital across the street. So this was an 8-year-old girl coming in with a foot injury. Her mom said that she was bicycling with flip-flops and her foot got caught in the chains. Again, graphic pictures. So here's her toe that came in, partial amputation. Better view here. And then here's the little nubbin that she brought in. So for this case, this was actually all soft tissue. There wasn't really any bone in this piece. And as you can see, the piece is very white and is just kind of sitting open to air. So this isn't something we reattach. You can't really reattach soft tissue pieces or small pieces. So what we do here is we take the exposed bone. We of course numb the patient up completely. We do a nerve block so the whole toe is, whole foot is numb. And then they'll actually, at the bedside in the ER, and I've seen this and I've helped with this, you basically take these sterile pliers and you cut the tip of the bone off that's exposed. You then take some skin down here and you flap it over the top and suture it or do stitches all the way around. And then they just kind of follow up in a wound care clinic and it heals up pretty nicely. So wear your shoes when you ride your bike. It's the moral of that story. This one doesn't have a patient image. It has an image of a note from the triage receptionist. This one's a little PG-13, but I had to share this one. This is my favorite story. So I'm going to pull the text up so you can read it, but I will also read it aloud. So patient comes to the ER from another hospital with a wedding ring stuck on his penis. Patient says he met a girl online. They were both in the process of a divorce. The female he was meeting up with said, "Bring his ring." The patient brought the ring and the female proceeded to place the ring in her mouth as well as his penis. Patient stated, "I got off, but the ring didn't." Best quote of residency right there. Tried to remove it himself, no improvement, swollen, enlarged. So I see this guy. He has a wedding band around it. It's big, it's swollen, it's purple and painful. We sedate him and we get our ring cutter, which is like a little Dremel drill. So it has a small like circular blade that spins. And we start cutting the ring. And there's sparks, there's smoke. We have somebody spraying it with flushes to keep it from getting too hot. And as I pull the blade away, the ring doesn't have a dent in it, and the blade is gone, like disintegrated. So I asked, "Sir, what is this ring made out of?" And he said, "Titanium." So, okay, well, we had to scour this large hospital for our only diamond tip blades, which are in the urology operating rooms. So we find those, and about an hour of cutting, we finally get the ring off. So moral of this story, don't put anything down there that you can't cut. I was actually working in our fast track area when I went up. We were pretty slow, so I went up to the trauma area to help, and they were very busy, and this guy just kind of rolled in. So It's just a stroke of luck that I got to take care of him. This next one here, lawnmower versus hand, another traumatic injury. So this was a 62-year-old guy. He was cleaning the bottom of his lawnmower. It was off. He's just getting some of the old grass out, and a bee flew underneath. And so as a reaction, he pulls his hand out, and of course he catches his finger on the blade. Pretty clean cut, actually. Again, no bone is exposed here. He wasn't really in much pain either. Just all soft tissue, like skin, fat, muscle. So same thing with the foot I talked about earlier. We just did a revision amputation, which is where you just kind of cut the soft tissue down and flap a piece of skin over. So this one, 4th of July is always fun in the ER. Firework versus hand. I mean, I don't really have much else to say other than this. So this guy had a revision amputation on this finger, and his thumb. And then he had a bunch of tendon injury here that had to be repaired by a hand surgeon, a plastic surgeon in the operating room. So in these scenarios, we make sure the patient's not bleeding out. We make sure they're not injured anywhere else. We make sure that their pain is controlled. And then we get our specialists to come and help us out. All right. This lady, she was 64. She had a motor vehicle crash, and she was thrown through the windshield. She came in, she was not responsive. So the first thing we do in all of our traumas, all of our big traumas, is we go through our ABCs, airway, breathing, circulation. Those are the first 3 things you need to evaluate with a patient for life-threatening injury or illness. So as far as airway, she wasn't breathing on her own, likely from her mental status, from hitting her head, from getting in this car accident. So we immediately placed a breathing tube. We went to breathing to make sure she didn't have a dropped lung, which can be fatal as well. And then you go to circulation, make sure all her pulses are okay. She doesn't have any injuries to her blood vessels where that could compromise her, her legs, her arms, anything like that. And then you go back after the ABCs and do your secondary survey where you evaluate everything else. It can be very difficult because there are injuries that are hard to ignore, but you still have to stick to your regimented ABCs or else patients can get much sicker and crash while you're taking care of them. So this is her injury. This was a complete scalping injury. She went through the windshield and the shard of glass cut her as she went out. As bad as this looks, it actually completely avoided her eye, which would have been much more of a difficult fix. With this, we actually just sutured it back on after we cleaned it out really well, and it healed up pretty nicely. So, all right. Now we're going to move on to my bug segment. We see everything in the ER, like I said. That includes bugs. The first one was actually, oh yeah, this one's pretty bad. So this was a 40-year-old female. She got into a motor vehicle accident and went to an outside hospital. She had a laceration on the top of her head, and she left AMA against medical advice to go out and use her drug that she was addicted to, and didn't return. She never got the wound washed out. She never got it repaired. So she came to our hospital a week later stating that her scalp was itchy and she wanted it checked out. And so this is a video here. Let's see if I can get it to play. One of the more graphic videos that I've had. Actually, the maggots kept the wound from getting infected. So we took her to the operating room, plastic surgery. They debrided the entire wound, took out all the maggots and everything. But once they cleared out just kind of the debris, they said there was no infection. They washed it out. They just kind of cut a nice margin to make it kind of circular. Excuse me, so they could do a skin flap or skin graft. But otherwise, the wound looked pretty good. So similar to maggots, we can use leeches to aid in healing. So we had a 55-year-old who came in with a femur fracture, thigh fracture. It was an open fracture, meaning it went through the skin. And she had to get a skin graft on that area called a flap. A flap is a thick skin graft. That flap wasn't doing very well. They have to kind of reattach some of the blood vessels, and sometimes the blood can't drain out very well. So it started getting very engorged and swollen, and they had to relieve some of that blood and pressure. But if they cut into it with a scalpel, they were going to compromise the integrity of the graft. So what they did is they used leeches. These are pharmacy grade leeches, meaning there's a tank in our pharmacy with these just kind of hanging out. And as the intern in the ICU, it was my job to wrangle these guys and put them on and take them off every 8 to 12 hours. You also got to count and make sure one doesn't crawl away. So it's actually really interesting. I didn't realize that they'd still use these, but it worked pretty well. All right. These are the last few pictures I have here. These are all psychiatric cases. These are patients who, for whatever reason, had decompensated psychosis and harmed themselves. So the first patient, these are afterwards. This was a person who cut off their own hand with a circular saw because he had the mark of the devil on it. This patient actually went up to psychiatry, got treated. This is the first time he experienced psychosis like this, but he had a history of depression and bipolar disorder. And after a few days of treatment, he actually kind of came to and was, very, very upset, very regretful, and is maintained on therapy and doing well. This patient is recurrently psychotic and has decompensated schizophrenia, frequent hallucinations that tell him to cut his fingers off. And this was his third digit, I believe, that he cut off. His family states that they would come home and find his fingers kind of randomly in the house. One was sitting upright on the table, kind of like a shrine, I guess, with some candles around it. But he's been treated and is on medication and hasn't been back to the ER for harming himself in a while. So I think he's doing well. This last picture is probably my most graphic. This one is a patient who was recently in the ER. This was 2 weeks ago. Transgendered male to female who had a history of major depressive disorder, decompensated with psychosis, and decided that they wanted gender affirming surgery and took it upon themselves to do it to themselves. So they are in the psychiatric unit. They went to the OR to have this repaired, and they're getting treatment now. And they're still pretty sick, but they're doing much better. So those are all of my cases. Again, I apologize if that was a little too graphic for some of you, but the ER is an interesting place. We have tons of trauma. We have tons of sick medical patients. A lot of the sick medical patients and some of the crazy lab values I didn't present because I didn't think that would necessarily, people wouldn't really understand a whole lot of that if you're not in the field quite yet. But we also have a leaderboard in our lounge or residency lounge that has the record-breaking lab values, like the highest sugar, the highest blood count, things like that. So that's always fun. But seeing these crazy cases and following them up and seeing how they turn out, knowing that you were the one to stabilize them initially is super rewarding. And then the pictures are always crazy and fun to keep.
Well, first of all, thank you so much, Adam, for gathering this presentation together. I personally did not expect all these stories out of emergency medicine. Like in general, you would think, yeah, I'm sure some crazy stuff happens in the ER, but myself and quite a few people in the comments can definitely agree that those are some pretty interesting stories out there.
Yeah.
Makes for some some interesting conversations for sure. So I really do
Yeah.
appreciate you for sharing the cases. Just to go through some questions as we wrap up, we might go through 3 or 4 questions if that's not a problem with you.
Sure. Yeah, I have time.
Okay, sounds good. First question is, and you mentioned this earlier on with your pros and cons. You touched on it. How do you go about really managing your work with your personal life, especially as a resident at the moment? What's your balance?
Yeah, so that's a great question. It varies depending on your specialty, and it varies depending on your personality. So I am very much in the camp that I need to have something outside of medicine. I have to do things outside of medicine to decompress, especially with some of the stuff we see in the ER, as you can imagine, can be very traumatic. So there are requirements within residency. So when you're off, you still have to do things like study, things like, different research projects, stuff like that. I find that emergency medicine is a lot less time intensive than others, especially surgical services. So the ACGME, which is the governing body of all graduate medical education, all residencies in the country, have a duty hours requirement, meaning you cannot go over this many hours per week. The limit for all specialties is 80 hours a week, which sounds insane, but it's much less than it used to be. For emergency medicine, our core group, the ABEM, the American Board of Emergency Medicine, has made its own rule where our cap is 60 hours a week. That's just for our specialty. That kind of goes to show that emergency medicine in general is much more proactive in taking care of its people, its residents. So to answer your question more specifically, the switching, like I mentioned, is very difficult. It takes me about a day and a half to kind of really switch from a night shift schedule to a day shift schedule. But otherwise, I probably work on average 3 shifts a week, 4 shifts a week, depending on if I do a 12-hour. So I have a good amount of time off. My program in particular, and I think the specialty is kind of like this, we always have something going on. We're always going out after shift. That's another big thing that we like to do, even if you're working in a row. So on our 11 p to 7 a shift, which I'm going into tonight, we'll all go to breakfast afterwards at 7 a.m. Our 3 to 11 shift, we'll go to one of the local bars not too far away that closes at 2 a.m. after shift, grab some drinks, talk about the shift. We have a social committee. I'm actually the president of our social committee right now. We have funds and we throw things like our Turkey Bowl, which is our annual football game of surgery versus ER, which we won this year, just by the way. The prize is the golden bedpan, which is actually a golden bedpan that we have mounted up in our lounge. Things like that. So emergency medicine in general prioritizes wellness much more than a lot of other specialties.
That is great to hear. I know for some people, especially just even, let's say, going through the application cycle, which is going to be coming up for some with medical school this summer, they already feel the tension between work or study, at least in life. So I'm sure that's valued for some. A few other questions. Our next one is, do you know of any DOs in emergency medicine? How prevalent are DOs?
Yeah, absolutely. So being a DO, it does put you at a disadvantage overall in applying for residency after med school. I'm not going to lie. It's their programs look for more MDs than they do DOs. We have 1 DO per class, per residency class. And I mean, as far as attendings, I don't know, I would say it's not a huge percentage. It's about 10%. I would say 10, 20%, 10, 15, 20% of the ER attendings are DO. But I think, honestly, I think DO school translates pretty well into emergency medicine. And then I have a lot of buddies who went to DO school who ended up going into ER as well. ER or family, I don't really know what that's about. Like all the DOs I know are either ER or family med.
Yeah, it's emphasized on primary care in general.
Yeah.
Next question, this circles back to our initial question. Do you feel like when you leave work, when you clock out, you can actually, by your mindset, you can leave work at work, so to speak? Is that something that you struggle with or comes naturally to you?
Yeah, so it kind of has fluxed for me. Initially, it was easy. I did the transplant service, and I saw some traumatic stuff there with the bodies that we got in for harvesting, because we had to get them within 10 hours of death. So we saw all ages from my youngest was 2 years old all the way up to 90, and you had to take out their bones essentially. So I may have been already accustomed to it, but it starts to wear on you a little bit. We've had lectures, we have people who come and talk to us about it, people that are our attendings, our supervisors, our direct bosses, telling us about their trauma, to kind of normalize it. And we have free counseling through our residency program, which most, if not all, do. And I encourage everybody to take advantage of that, even if they're not necessarily struggling, just to have kind of a third party to decompress with. And then, like I said, a lot of the post-shift events end up us venting or talking about a lot of these things. Sometimes we mask it with humor, sometimes we mask it with like just bitterness at the system, but it's all just a way for us to vent and get some of this off our chest. So we finish work, we go out afterwards, we get it all off, and then we go home and we can kind of, take a breath. But it is difficult, especially in that trauma area, going for 12 hours, 8 hours, just on your feet, nonstop, balls to the wall, seeing crazy stuff. And then all of a sudden you sign out and you're done and you got to go to bed. It's definitely a something to get used to, and it can be difficult for some.
Absolutely. Also, I just wanted to follow up. You mentioned that the limit is 60 hours a week for at least emergency medicine residents. For attendings, how many hours a week do they work typically?
That's contracted. It depends.
Okay.
So if you're part of the administration, you can get buy down, meaning you do other stuff to pay for your work. So most people will work 30 hours a week, but if you do administrative tasks or teaching tasks, that will buy down some of your hours, so you only have to work 12 hours a week. But then you're expected to perform a certain amount of other duties.
Okay, I see. So it's a split between clinical and admin for them then. Okay. All right. And one more question to wrap up. The comments were talking about the interesting use of leeches in one of the cases. So one student asked, what other organisms outside of leeches or like leeches are used to help with injuries? Is that really a common thing, or does that apply elsewhere?
It's not common at all. No, it's kind of a last line therapy for a non-salvageable procedure, graft in that case. There are some places that are using maggots as well, specifically for wound debridement in patients that would be poor surgical candidates. Other organisms, not that I'm aware of.
Yeah.
Leeches and maggots are the big ones, I think.
It was surprising just to hear that they were involved in these cases. I don't think we're almost through 60 plus shadowing sessions. Yeah, this is our 58th. So in all those shadowing sessions, I think this is the first one where something like leeches have come into play. So.
Well, fun fact for you all, maggots really hate lidocaine, numbing medicine. So somebody has like a wound with maggots in it, and you pour lidocaine, they all pop their heads out like little gophers, and you can just pick them out.
That's cool. All right.
Tips from the ER.
Yeah. Well, I think that this was such a great session. I know that a lot of students on here enjoyed it. And if we can have some thank yous in the chat for Adam, he took some time to get this presentation together. And there's his email for anyone who has any questions for him. I'm sure some students will be shooting over a few questions for you. But to those listening, I have some last reminders to say, especially to those seeking out credit for your attendance. So our team has created a quiz. It's now available in the chat, in the same chat box that y'all have written out your questions, and also on our website, on our virtual shadowing page. We have a few pages. Go to our virtual shadowing page, just at the very top right. Click there, and you'll see the quiz available. If you just scroll down to the future speakers heading, right there, you'll see a Monday quiz on the left, a Thursday quiz on the right. Click the Monday quiz and you'll be directed to a Google form. That Google form or quiz will be due at 11:59 p.m. Central Standard Time this Sunday, February 5th. We're going to be continuing with more shadowing sessions. So later this Thursday, we're going to be joined with a cardiologist. We're going to talk about cardiology. And this is an attending cardiologist. I think he just wrapped up fellowship. His name is Dr. Edesina. He's interested or passionate about clinical prevention, community outreach, and solving healthcare disparities. Definitely something to look forward to. I think it's been a while since we had cardiology on shadowing. A few more things also about the quiz. For those who are taking it, and once you hopefully do pass that quiz, you need to earn 60 or more, 60% or more in order to pass the quiz. So 6 out of 10 questions or more. Once you do that, you'll receive a certificate, which will be sent to the email inbox of the address that you list on the quiz. Be sure it's an address that you use often. So for example, we highly encourage a personal Gmail or Yahoo account. Sometimes with school emails, it filters out. And just in case you don't receive it in your inbox, please check your spam folder. If you happen to not receive it in both, feel free to shoot us an email and we can help retrieve it for you. But like I said, we're going to have a session later this Thursday, February 2nd at 7 p.m. Central as always. We'll be posting that on our Instagram pretty soon. So just a last thing, if y'all have any questions, feel free to email us at community.h4h@gmail.com. And we post on both our Instagram page and we send out these flyers through our listserv. So both are great ways that you can get in touch with us. But that's going to wrap it up for today. I really do appreciate you, Adam, for taking the time to gather this. This was definitely an interesting session. A very memorable one, and we see all these thank yous rolling in the chat. So thank you again, honestly, for getting this all together. This was such an enjoyable session. I'm so glad that we kicked off our spring semester with this. And any questions from any students, feel free to email Adam at his email there. Yep. I'm sure that he'd be happy to answer. But that's really going to wrap it up. So thank you all for joining in.